Okay, why is the multi-chat function that's supposed to have my YouTube chat and my Twitch chat just doesn't show my YouTube chat? What the frick? What the flip? We're live on YouTube? Yeah. I'm just like that. Hello, Taylor Joseph Rummel. Why does it not work? It worked that one time. Oh well. Do. Okay, bye. Liver, my favorite woman stream girl. Liver. Hi, Jaden. Where is this at? You guys, perfume and cologne, that shit is so broken. Y'all gotta get on that shit. Loki. Were night oats? Don't they look cute? And my smoothie milkshake thing. Should I get more badges? Change the color and shit? I haven't gotten new, like, emotes or badges or anything in a very long time. I would have to get a new artist, I think. Who is your emote artist? You know. I am not taking summer classes. Not possible, actually. Our school doesn't have summer classes. Everything is like, this is what you're taking. These are your time slots, and you don't get to pick anything. Wah wah. Little beach poo. Heart is scary. It is really cool. Why does he hate you? Why did he wake you up? I don't know how I'm supposed to remember this. I was like, I can just make sense of it. It doesn't make sense to me. But also he glossed over it. So maybe it doesn't matter that much. Whatever. By overnight oats. Be right back. Your title is great, by the way. Thank you. This class is called Clinical Diagnosis. Like, am I supposed to just know this? my god. I got that notification and I was super confused. I'm like, what? Why, like, is this my lecture? Hi, Ven. Thank you for the 10 from Ven. Realize that you guys can't hear that again. Here, I'll play it again. Like how confused I was.
Blah.
I was like, where? Yes, you lecture did that. Okay. A lot. He's unimpressed.
I know what I want and I take it when I want it. Ought to realize that by now. Quick. Get into the front seat, George. Stop the car, you fool. It's finished. The rest is easy.
Hi, Parker. Hi, Gibby. A Fallout one. This is keeping me productive, is it? Excuse me. The $200 Fallout one? Damn. No, I don't mean the bet. I want to get the $200 Fallout final. I think that'd be very nice. How expensive is the thingy? And its name. The got it for 50. Wow. Finals are usually 30, so why is the Fallout one 200? fuck is it called? What what's this thing that plays finals? A turntable or a record player. Yeah. Are they really? That's resale? Oh, that's fucking crazy. Summer Summer breaks after my last exam, which is on the 23rd. Super close, yeah. I just have 4 exams in between here and then. What do you mean by that, Parker? What do you mean by that? You got too much. You're too Kenna brained. She was going fucking crazy yesterday. She wanted you bad. Yeah, I had to leave chat. I was like, this is really, 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 like, kind of sad and cringe. I was like, I'm so good, actually. Combine our weight. No, he wants to have sex on the bed with you, Ven. Wait, you got a bed frame. That's good. Do you have a mattress? That's good. It's just the frame. So now you won't have back pain anymore, kind of. Parker, are you like looking for a job right now? Is that what's happening? 3-inch mattress topper. 3-inch mattress topper. Why do you need a mattress topper? Is your mattress not good enough for you? I think I need to cut my fucking bangs again. This is so annoying. Mattress topper is meta. Mattress topper. I honestly, I think I have one. It's a super ghetto one. I have a memory foam. But like this sick. But since it's for like a twin bed, it's all right. I've been trying to sleep on my back now because sleeping on my sides have been just fucking my back up. So I took the memory foam off because it's more comfy to sleep on harder shit. But then now I can't sleep on my side if I want to. Because the mattress is so fucking hard. You're a stomach sleeper? That's an oh no. That's a big oh no. Maybe not. Oh no, I don't know. I think it's oh no. I don't think it's good. Future back problems. Technically, sleeping on your side is like not like bad. I just got this like chronic incredible pain in like my ribs, like over here. And basically my I got a chiropractor to look at it, and he's like, yeah, I think because my hip and my shoulder, like, because they're just like so far out, my stomach is basically doing this, like I'm sinking in. Basically my hips are too wide. And I can solve that by like putting something underneath it. Or I can sleep on my back. And sleeping on my back has been okay so far. Oh. Mickey will fix me. Well, no. Burger, I hope you know that, like, I will probably not be visiting you next time I go to LA. We'll see, though, because, like, I've known Peach longer than you, and I was like, yeah, I'll go visit Peach, and then I don't. But also, she lived in San Diego. Not even food, maybe. But also, I haven't gone to see Harrison yet. And he has a cat. So... she moved. She was in San Diego. A 2-for-1 with Klaxonite, but I don't even know Klaxonite really. Also, I think he... never mind. I'll buy food. You're buying food for me and Dylan? I'll think about it. What the fuck? You motherfuckers cannot be real. They're like, yeah, you can feel your heart. No, you guys are so bullshit. Like, what do you think this is? Y'all are so bullshit. You're too low? It's like up here. Maybe it's because I got tits. Tits. Like, I feel like you guys are so bullshit for saying that I can... You guys are so bullshit, I won't lie. A little bit bullshit. Okay, whoa, he's yapping a lot. I have to be right back, actually.
Where is this? Where am I?
Do not be alarmed, my friend. My man Ivan found you out on the cliff. Brought you here to be taken care of.
Well, thank God there's life on this island. I hardly believed.
Few people do. You are quite safe here at my castle, Mr.
Rainsford.
Yes.
Rainsford. I'm Sanger Rainsford of New York.
Rainsford? Sanger Rainsford?
Yes.
Well, it is indeed a very great pleasure and honor to welcome you, Mr. Sanger Rainsford. You're the celebrated hunter, not?
Yes. You know me?
By reputation only. I've read your book about hunting snow leopards in Tibet, you see. My name is General Zaroff. I am not English, Mr. Rainsford, but I went to a good school. Perhaps you recognize the colors of my tie. No, makes no difference. I've lived too long in the jungle to be a snob.
Well,
Thank you. I was calling Dylan and he messaged me 2 separate times today. I'm gonna take my Adderall and then I'm gonna take a nap and then I'll get up. So I'm like, first time I'm like, okay, like that's normal, great. Second time he's like, I'm gonna take my Adderall and take a 30-minute nap. I'm like, you already said that you're taking your Adderall. Oh. and then just now he's like, yeah, I haven't taken my Adderall yet. I'm like, that's great. Okay, enjoy. Good luck. Have fun, Ben. Yeah. Oops. Okay. We have an E module that we have to do. So this is
I welcome all of you at every
Thank
level.
you.
Anyone who now or in the future will be caring for patients.
Great.
From a beginning medical student through a practicing physician, nurses, nurse practitioners, physician assistants, paramedics also have to know a certain amount of bedside findings. We're going to boil all this down for you. My colleagues and I, for many years, have been involved in teaching cardiology that emphasizes bedside skills. It started for me with my exposure to W. Proctor Harvey, one of the greatest bedside clinicians and teachers that ever lived. And that was way back in the mid-1960s. And we want to bring that to
God,
you.
you're
Boil
old.
this all down.
Sorry,
It's simple.
I don't mean it.
You know, you might think that these skills are mysterious. They're not. But also, if you never drove a stick shift car, you might think that's mysterious. It's not. It's just learning how to do it. So that's what we're going to take you through. And we're going to tell you certain facts on which this is based. And those facts are very important for you to understand the rationale for how we evolved into these big 12 that we're going to learn together.
The goals of this program
Heck
are very
yeah.
focused. The first is for you to recognize the most important cardiac auscultatory findings. The emphasis is on auscultation, recognizing that other bedside skills, including assessment of the arterial and venous pulses and precordial movement, are also important. The second goal is for you to understand and be able to outline the basic physiology and pathophysiology associated with the important auscultatory findings. The emphasis is on basic explanations, recognizing that complex and multiple mechanisms may account for a given finding. When experienced cardiologists and generalists are asked to identify the most important bedside auscultatory findings, there are a dozen findings that are most often mentioned. We shall call them the Big 12. The findings include 4 heart sounds, second sound splitting, third and fourth diastolic filling sounds, and systolic clicks. The most important murmurs are the early systolic innocent murmur and those of the 4 classic left-sided valve lesions, mitral regurgitation and aortic stenosis in systole, and aortic regurgitation and mitral stenosis in diastole. To these may be added the murmur that is continuous through the second sound from systole into diastole, the right-sided murmur of tricuspid regurgitation that may augment with inspiration, and the pericardial friction rub with components in both systole and diastole. Not all of the Big 12 findings are of equal importance. For example, filling sounds are amongst the most important, as they may reflect ventricular function. The 4 classic left-sided valve murmurs are also very important. You should also be able to identify findings beyond the Big 12, but our goal is to maintain our focus, and once the Big 12 are mastered, other sounds and murmurs will be easier to identify.
And now I'm going to tell you exactly how to learn bedside skills. There are several simple rules, and if you follow them, you will learn the Big 12, and you will become accomplished at the bedside cardiovascular examination. Rule number 1, have an orderly approach. Dr. Harvey has popularized the 5-finger approach. And for the bedside examination, those 5 fingers are the appearance of the patient, assessing the carotid arterial pulse, the venous pulse, chest wall movement, and auscultation. And we shall emphasize auscultation and use the other fingers as backup to put it all in perspective. The second very important thing is memorize something. Don't memorize anything else in cardiology, but do memorize the pressure and the volume curves. If you understand the pressure and the volume curves, you'll understand why the heart sounds occur and why blood is flowing. For example, whoop, first heart sound. Why? Because the pressure rises higher in the left ventricle than it is in the left atrium. Yup. Why? The second heart sound. Because the pressure falls lower in the left ventricle than in the aortic root. We're going to review those carefully. Flow. Remember this rule, that during the first 1/3 of systole, 2/3 of blood leaves the heart. And during the first 1/3 of diastole, 2/3 of blood fills the heart. So if you have events due to flow alone, they will occur either early in systole or early in diastole. Why? The second heart sound. Because the pressure falls lower in the left ventricle than in the aortic root. And we're going to review those carefully. Flow. Remember this rule, that during the first 1/3 of systole, 2/3 of blood leaves the heart. We're going to review those carefully. Flow. Remember this rule, that during the first 1/3 of systole,
Systole.
2/3 of blood leaves the heart. And during the first 1/3 of diastole, 2/3 of blood. Blood fills the heart. So if you have
Oh, fills the heart.
flow, remember this rule, that during the first 1/3 of systole, 2/3 of blood.
I'm just gonna write this down. first 1/3 systole, 2/3 blood leaves heart.
That during the first 1/3 of systole, 2/3 of blood leaves the heart. And during the first 1/3 of diastole, 2/3 of blood fills the heart. So if you have events due to flow alone, they will occur either early in systole or early in diastole. The next very important thing is practice, practice, practice. On patients ideally, but in the absence of patients, it has been proven that simulation techniques, Harvey, heart sound tapes, heart sound simulators will teach you heart sounds and will teach you heart murmurs. And when these skills are learned on a simulator, they can be transferred to real patients. In some ways, simulators are a benefit because they take out the background noise that can occur in a very complex patient, and you can focus. You can focus. The next very important thing is to involve yourself with mimicry, and we're going to practice that together. If you mimic those heart sounds, you will start thinking about the hemodynamics and the pathophysiology. It's very important. It's the world's least expensive system of simulation. And finally, test yourself. Test yourself on patients, on heart sound tapes, on simulators, any way you can. Education is driven by testing. Test yourself, and then take all of what you've learned and transfer it to the patient and practice, practice, practice.
To review again, the 5 fingers of the cardiovascular bedside or physical examination include the evaluation of the patient's general appearance, venous pulse, arterial pulse, precordial movement, and auscultation. Auscultation will be emphasized in this program. Left ventricular systole begins with the first heart sound.
Precordial movement. Precordial movement.
Or S1. It occurs as the pressure in the left ventricle rises above that of the left atrium. The mitral valve closes, and the sound occurs as the valve leaflets stretch and become tense. The first heart sound occurs just before the carotid impulse and is loudest at the apex. As left ventricular pressure continues to rise above aortic pressure, the aortic valve opens. Normally, no sound is produced by valve opening. Systole ends and diastole begins with the second heart sound, or S2. It occurs as left ventricular pressure falls below that of the aortic root. The aortic valve closes, and the sound occurs as the valve leaflets stretch and become tense. The second sound occurs at the end of the carotid impulse and is loudest at the base. As left ventricular pressure falls below left atrial pressure, the mitral valve opens, a normally inaudible event. Cardiac blood flow is maximal in early systole and early diastole. Approximately 2/3 of the blood ejected leaves the ventricles in the first 1/3 of systole, and 2/3 of the blood filling the ventricles enters during the first 1/3 of diastole. This information is useful when analyzing the significance of certain auscultatory events. When you recognize a finding during your cardiovascular examination, you begin a problem-solving process at multiple levels. First, you demonstrate the skill to identify the finding. Next, you begin to interpret the pathophysiology associated with that finding, and that leads you to define a differential diagnosis and estimate severity. Finally, you may be able to make a management decision by correlating the bedside finding.
How's it going? I'm gonna EB.
With other available clinical information.
Shit, hi. What?
1/3 of diastole. When you recognize a finding during your cardiovascular examination, you begin a problem-solving process at multiple levels. First, you demonstrate the skill to identify the finding. Next, you begin to interpret the pathophysiology associated with that finding, and that leads you to define a differential diagnosis and estimate severity. Finally, you may be able to make a management decision by correlating the bedside.
We're now going to learn essential bedside cardiology by examining Harvey, the cardiology patient simulator. You know, the use of a simulator for medical training is analogous to the use of books and articles for cognitive knowledge. And then, of course, you have to see patients. It's the same with a simulator.
5 a.m. Why are you awake?
And the skills learned on a simulator, in fact, do transfer to live patients. Now, a
Go
word before we
sleep.
examine Harvey about the stethoscope.
Good
The
night.
bell of the stethoscope is critical. It is imperative to use this to listen for low-frequency sounds, such as filling sounds. And we will practice that together and use the proper head of the stethoscope, the diaphragm for the more high-frequency sounds, and the bell for the more low-frequency. Now, we're going to begin by listening at the upper right sternal edge to get the cadence of the first and second heart sound. Those can be mimicked by What we're going to do is use the carotid as a timing device. You don't do this with patients, but it's very helpful for timing here. And when the cotton swab moves, it's systole.
Oh.
As it moves,
You slept so early last night.
first and second sounds at the upper
I guess not
right
really.
sternal edge, and you'll be able to think of the hemodynamic curves, and you'll be able to envision why the mitral valve is closing to cause the first sound, the AV valves, and the second sounds are caused by the closure of the semilunar valves. Everyone listen together. What we heard was lup-tup, lup-tup, lup-tup. You should mimic that. Go ahead and do it. Lup-tup, lup-tup,
Lup-tup.
lup-tup. It's lup systole dup, lup systole dup, lup-tup, lup-tup. We're on our way to learn essential bedside cardiology.
Thank you so much.
Auscultation is usually begun at the aortic area. The stethoscope is then sequentially moved to the pulmonary, tricuspid, and mitral areas. Keep in mind that murmurs may radiate widely.
Oh,
and they may be present in areas
I
other than the
see.
sounds described. Inching the stethoscope across the chest is a useful technique to define the area where a given acoustic is best heard.
Yum, yum,
As a
yum.
result, one should selectively tune in on the individual sounds and murmurs that may be present. The first and second heart sounds we heard at the upper right sternal edge are normal.
It's fair.
They are single and are normal in intensity. The
Lup-tup.
second sound, S2, is normally louder than the first sound, S1, in the aortic area because the stethoscope is closer to the. Always keep in mind.
Oh shit.
The first and the first and second heart sounds we heard at the upper right sternal edge are normal. They are single and are normal in intensity. The second sound, S2, is normally louder than the first sound, S1, in the aortic area because the stethoscope is closer to the aorta than it is to the left ventricle. The relative intensities of heart sounds may be clues to pathology. For example, a loud aortic closure may be seen in some patients with hypertension. This is a graphic example of the left heart in a normal patient. In the animation that follows, we can appreciate that the first heart sound on the left side is associated with closure and tensing of the mitral valve, and the second heart sound on the left side is associated with closure and tensing of the aortic valve. Always keep in mind the events of the cardiac cycle. In these left heart pressure tracings, S1 indicates the beginning of systole and coincides with closure of the mitral valve. S2 indicates the end of systole and the beginning of diastole and coincides with closure of the aortic valve.
My biology would make me hell yeah.
And surrounding cardiac structures and blood
Full of soapy water. Water.
that result from valve closure and the ensuing deceleration of blood flow.
But where do peanut butter? Big.
First essential finding we're going to learn together is normal splitting of the second heart sound. Now, when you examine a patient, you assess all of the findings. Remember those 5 fingers? And Harvey has those findings. Carotid arterial pulses, jugular venous pulse, chest wall movement, a little tap in early systole, breathing that may vary the acoustic events. We are going to focus on auscultation. In this case, we're going to listen at the upper left sternal edge with the diaphragm of the stethoscope where you best hear splitting of the second heart sound. Everyone listen together, and we will use the carotid vessel as a timing mechanism and place a cotton swab on it so we can identify systole. Everyone listen together.
Did you do it?
Watch breathing. And what did we hear? As the patient breathed in, we heard lup-tudup, lup-tudup, lup-tudup. Breathe out, lup-tup, lup-tup.
Do we?
You do that. Lup-tudup, lup-tudup, lup-tudup.
I can't roll my R's, sir. I can't do that. Sir, I'm not hearing what you're hearing. Oh, I did.
Identify systole. Everyone listen together and watch breathing.
I feel like I'm hallucinating though.
And what did we hear? As the patient breathed in, we heard lup-tudup, lup-tudup, lup-tudup.
Cream tea? What? Oh. Makes me gag, really. Huh.
You do that. Lup-tudup,
I can't.
lup-tudup, 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 lup-tudup.
I can lup dup lup dup.
Lup-tudup, lup-tudup, lup-tudup.
I can't lup dup dup.
Why did we hear that? The patient breathed in, that dropped the pressure in the chest, then a bit more blood went back to the right heart, delaying pulmonary closure, but also pooled in the lungs, therefore a little less went to the left, and the aortic closure was a little bit earlier. So then you get lup-tudup, 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 lup-tup, lup-tup.
Lup dup lup dup.
And the behavior of the second heart sound can be a critically important clue to a diagnosis. For example, in a patient with an atrial septal defect, you may hear a flow murmur coming out in the upper left sternal edge area, and most importantly, the second heart sound remains fixed split. Lup-tudup, 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 lup-tudup. It never varies.
Say again, I wasn't listening.
The second heart sound remains diagnosis. And the behavior of the second heart sound can be a critically important clue to a diagnosis. For example, in a patient with an atrial septal defect, you may hear a flow murmur coming out in the upper left sternal edge area, and most importantly, the second heart sound remains fixed split. Lup-tudup, 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 lup-tudup. It never varies. And even sometimes, the second heart sound can split in expiration. That's called paradoxic splitting if there's a reason for delay of left side ejection. Remember normal splitting, mimic it, remember it. Lup-tudup, 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 lup-tudup.
Abnormal splitting of the second heart sound occurs in a variety of pathologic conditions. It may be the key to a diagnosis, as in patients with atrial septal defects who have fixed splitting. Normal children and young adults may have persistence of excitory splitting when supine, but this typically disappears when they sit or stand. The relative intensity of the second heart sound may reflect underlying pathology. Normally, the aortic sound is louder than the pulmonary because it closes at a higher
My
pressure.
god.
In systemic hypertension, the aortic sound may be further accentuated, and in pulmonary hypertension, the pulmonary sound may be increased. In aortic and pulmonary stenosis, one component may be diminished due to valve immobility. This is a graphic example of normal inspiratory or physiologic splitting of S2 in which the first component, A2, is normally louder than the second component, P2. Let us listen together.
Constant tachycardia, and they have no idea why. Oh no. Do they put her on beta blockers? Let-it-oop, let-it-oop. Wow.
We have reviewed the findings of a normal patient at the upper right and upper left sternal edges. At the upper right sternal edge, we heard only the first and second heart sounds. At the upper left sternal edge, we heard normal inspiratory splitting of the second heart sounds. We shall now listen at the lower left sternal edge in a normal patient.
Oh, I
We shall hear
see.
splitting of the first heart sounds. While this finding is not one of
That's
the 12,
unfortunate.
it must be differentiated from other acoustic events. Let us listen together.
Chronic abdominal pain. They have no idea why. What the fuck?
The normal first heart sound may be single or split. Splitting is due to asynchronous mitral, then tricuspid valve closure. The evaluation of first heart sound splitting is of limited diagnostic value, although it may reflect pathology. For example, wide splitting due to delayed tricuspid closure is seen in patients with right bundle branch block. Most important, split burst sounds must be differentiated from other acoustic events, for example, a fourth sound and a first sound. Let us listen together. Note that both components of the first sound are high frequency.
I can't.
We have reviewed the findings of a normal patient at the upper right and upper and second. We shall now normal patient, where we must be differentiated from other. The normal first heart setting is of limited diagnostic value, although it wide split is seen in patients from other acoustic events. Let us listen together. Note that both components of the first sound are.
That's so crazy.
The next extreme.
That sucks. They just have no idea what's going on. Bro, Parker. Can we eat a proper meal? Can we be a real boy? That thing that can happen. I had cucumbers before this. Okay, can we have a proper meal? Tahini. Have a banana too. What are you, like a 50-year-old white just suburban mom that's trying to get fit for the men? Racist? My fault. Tell Aggie. Okay.
In my opinion, all sounds and murmurs are not created equal, including the Big 12. Filling sounds are.
It's basically a full meal. Okay, y'all.
Extremely important, and the third heart sound is an example of a filling sound. Now, we're going to continue to examine this normal patient, although a third heart sound can also clearly be abnormal. But let's listen at the apex in this normal patient, and critically important also, you listen with the bell so that you enhance the low frequency sound, and you bring it out and you readily hear it. And in your patient, you may want to lay them over in the left lateral decubitus position to hear it as the heart comes closer to the chest wall. Let's use the carotid vessel for timing, and everyone listen together. Let's use the carotid vessel for timing, and everyone.
We're almost gold. Big news. I like putting my hair into high ponytails, but I also don't want to, like, pull on these hairs. We're out of milk. Oh, might as well kill yourself, to be honest. In a game. Or whatever. Ew, I hate that. I've got some. Oh my god, so nice of you to share with Gosan. Teleport it to him?
Everyone listen together.
Let's listen together, you guys. That's normal, right? Tell me that's normal.
And what did we hear in this normal patient? We heard lup-da-boom, lup-da-boom.
I did not hear that.
Mimic it. Lup-da-boom, lup-da-boom.
Lupta-boom. Can't hear that.
So for timing, and everyone listen together.
Okay.
And what did we hear in this normal patient? We heard lup-da-boom.
Yeah, we definitely heard it.
You do that. Mimic it.
Lupta-boom.
Lup-da-boom. Very, very important finding. That's
Lupta-boom.
the third heart sound. And in this case, in the normal patient, it's due to the fact that blood goes rushing.
I can't hear it, sir.
diastole, and then decelerate.
Third heart sound.
The next closer to the chest wall. Let's use the carotid vessel for timing, and everyone listen together. And what did we
Why is it
hear?
only 5 big food?
Lup-da-boom, lup-da-boom. You do that. Mimic it. Lup-da-boom, lup-da-boom. Normal patient, it's due to the fact that blood goes rushing and accelerating into the ventricle in early diastole and then decelerates normally, but that sets up vibrations in the normal patient. but it could be
Um,
with a stiff, poorly compliant ventricle when the deceleration is enhanced. So the blood goes into the ventricle, decelerates more rapidly, and you hear the same thing. Lup the boom, lup the boom, lup the boom, lup the boom. It's a
Okay.
bedside reflection of ventricular function in that case, and it's an extremely important finding.
Third heart sounds are early diastolic, low-frequency filling
no,
sounds,
Pia isn't
best heard
that
with a bell
helpful
receptor.
here.
They
Leptaboom,
occur
leptaboom,
approximately 15
leptaboom.
hundredths of a second after the second sound and are related to the acceleration and deceleration of blood during early passive filling of the ventricle. Left ventricular third sounds may be heard in many normal children and young adults as blood rapidly accelerates into the ventricle. They may also be pathologic in heart failure as blood rapidly decelerates due to a less compliant ventricle.
I may
Left ventricular third sounds are best heard.
be.
Right ventricular third sounds are best heard at the tricuspid area and may augment with inspiration. This is a graphic example of the heart in a normal patient with a third heart sound at the apex. In the animation that follows, we can appreciate that the third heart sound is generated during early diastole,
I don't know.
and it is associated with rapid ventricular filling.
Leptaboom.
This is a graphic example of an S1 and an S2 followed by an S3. By simultaneously viewing the ventricular volume curve, one can appreciate that the third sound occurs just at the end of early rapid diastolic filling. Let us listen together.
Uh,
The next extremely important finding is a fourth heart sound. Filling sounds are very, very important. Patient comes to your office, describes distress in the chest, and you suspect angina. You listen to the patient carefully, examine them entirely, but at the apex, you listen
who
to
the
blood pressure on the bell,
fuck is
and you
Angela?
again, if the patient's in the left lateral decubitus position.
Parker, can we get our shit together? How are you gonna go to the gym and put on muscle if there's nothing to put on? Beans are protein? Yeah, but you need, like, calories. You don't know Angela? I actually do know an Angela.
Light pressure. For our purposes,
Leptaboom.
we'll put a cotton swab on the carotid vessel and everyone listen together. And what did we hear?
Whooped up.
A low frequency sound just before the first heart sound.
I'm good. I did it before you, sir. I am just better.
You can even feel that movement on the chest wall because it's low frequency and can move the chest wall. You mimic it. Now, what does that mean?
Whooped up.
This is a
Whooped
patient
up.
with angina.
I don't know what that means.
Ischemic
Angela?
is less compliant.
It's angina, isn't it? Pronounce.
Angina.
Angina. Who the fuck is Angela? Avocado toast last morning? Yeah. You mean I can't grow big muscles just by eating nothing but eggs? I mean, you probably could. You would have, like, it would be awful for your health. Hard boil. At least medium boil it. Voluptuous. That's true. No, but no. I say
Voluptuous.
He's technically saying, look. Sounds. We heard sounds. But I'm pretty sure he's saying voluptuous.
Low frequency sound just before the first heart sound. You do it. Mimic it. Voluptuous. Voluptuous.
Fuck you mean medium boil? You don't like medium boil? Have you tried medium boil? When I'm huge. No, there's a medium. There's a medium boil. Is there such thing as medium boiled eggs? You know, I'll just show you. Medium boiled eggs. Um, 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 well, because personally, I don't like soft boiled eggs. Because I don't like runny yolk. I like it when it's like soft to medium. Undercooked hard boiled eggs, that's not true. That's not true. That aren't runny. Henceforth, medium boiled. This is stupid. That's not true.
A good friend once told me everyone has their own way to hard boil an egg, and every single one of those people are very passionate about their procedure. I can't lie, I'm no different. I'm going to show you how to soft boil, medium boil, and hard boil eggs. They are perfect, and you can use them in a myriad of different recipes. I promise you, you will love these techniques. I'm sure you've seen one of these before. It's known as a chef toque. Many chefs wear them in a professional restaurant setting. Now, there are 100 different folds on a classic chef toque. Each of those folds represents the different ways a chef can prepare an egg. I'm not going to sit here and tell you or show you how to prepare an egg 100 different ways. In fact, there's probably more ways than that. What
I don't care. You're kind of annoying. Like, I'm sorry you guys are uneducated. That medium boiled eggs is a thing. Like, I'm sorry. He literally said the words medium. Because people are uneducated and don't know that medium boiled is a thing. Like, I'm sorry. Oh, hold on. I want my I want my my steak to be well done, but like not too well done. I want it like kind of red. But not like rare, you know? Medium maybe? Medium maybe? Look. Let me get my steak soft, please. Look. I'm now you know. You're welcome. You're welcome. You get to learn. Today you learned that medium boiled eggs are a thing. Like steak soft, please. No, please don't say that to people. Can I just get it soft? I just want it soft. Look.
You know, sometimes you can even
I don't know.
feel that movement on the chest wall because it's low frequency and can move the chest wall. You mimic it. Now, what does that mean?
It's like if I were to say a word that you don't know what it means, and you're like, only a certain amount of people know that word. Yeah, you're welcome. You're welcome. This is why we're educating. We're educating. We're teaching you guys stuff.
That ischemic myocardium
We're learning heart sounds
is the atrium in the
and
left
about
side.
medium boiled eggs.
Push that extra bit of blood into the ventricle. That ventricle is less giving, less.
Because there's no way you're gonna say, I'm gonna have a hard boiled egg. You want a hard boiled egg, and then you give me a soft boiled egg. I'm like, what the fuck is this shit? You're just mad because you're wrong. I don't know.
Compliance, blood decelerates more rapidly, and you hear bullupta, bullupta, bullupta. A very, very important finding.
Yeah.
The other
You're
important
welcome.
filling sound that may be heard at the apex is the fourth heart sound. It occurs in
The
late
sodium chloride.
contraction, causes rapid blood
Yeah,
flow
because you're not a
to the
smart ass.
If the ventricle is less
Medium boiled
contracted,
is not a smart ass thing. It's
rapid
just a
acceleration
thing.
of blood occurs and causes low frequency vibrations analogous to those occurring with a
Dominic Culture. Thank you. Thank you.
graphic example of the heart in a patient with hypertension.
Glad you're recognizing it.
Heart sound at the apex. In the animation that follows, we can appreciate that the fourth heart sound is generated during late diastole, and it is associated with left atrial contraction.
What's the next banana bread stream? Like never.
This is a graphic
I mean, I am going
of
home
the
soon,
fourth
but
filling sound.
I don't know.
Simultaneously viewing the ventricular volume curve, one can appreciate that the fourth sound occurs in late diastole at the time of rapid flow due to atrial contraction.
Thanks. You're welcome. You're welcome, Loco. Anytime.
Let us listen together.
I don't think I'm gonna get any of these questions right.
The other important
The next extreme important, and you suspect angina. You listen to the patient carefully, examine them entirely, enhance this again if the patient's in the left lateral to time systole, we'll put a. And what did we hear? We heard bullup, a low frequency sound just before the first heart sound.
It's not globally recognized? I don't know what to say. I don't know what to say. Should we, like, let's go ask some chefs? Do you guys know what medium boiled eggs are? Or like, what's global? Like, because I feel like if you ask anyone in the, like, kitchen scene, like if you ask anyone, no more arguing. For a medium boiled egg? I mean, I don't know. I don't know many people. So.
You do it, mimic it. Bullup, 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 bullup. You know, sometimes you can even feel that movement on the chest wall because it's low frequency and can move the chest wall. Bullup, bullup. You mimic it. Now, what does that mean? This is a patient with angina. That ischemic myocardium is less compliant, and as the atrium in late diastole goes to push that extra bit of blood into the ventricle, that ventricle is less giving, less compliant. The blood decelerates more rapidly.
atrial content and normal. This is a graphic example of in the and it is associated with
The
contraction. This is a graphic example of an S4 filling sound. By simultaneously viewing the ventricular volume curve, one can appreciate that the fourth sound occurs in late
Okay,
diastole
goodbye.
flow due to atrial
Have
contraction.
fun.
Let us listen together.
Seems pretty recognized. All I'm saying. That's all I'm saying. I don't know, that just kind of sounds normal to me. Does that not just sound like lepped up? Lepped up. I guess it's a little longer than lub. Like lube dube. Lubed up.
Last of the heart sounds in the Big 12 essential bedside cardiology findings is the
I have like short hair in the back. And this shit is so
This is a
annoying.
young lady whose mom and dad insisted she get a good checkup before she goes to college, totally asymptomatic. You examine her, no abnormal findings with the arterial pulses, venous pulses, chest wall movements. You listen at the apex with firm pressure on the diaphragm, timing systole again with the carotid vessel. You listen carefully. Let's listen together.
Oh, what dope.
What we heard at the apex was not just luptup, luptup, luptup. We heard an extra sound in mid-systole. It was luptup, luptup, luptup. Just a little high frequency sound. It's not easy to mimic, but you ought to try it because it does put the timing in your head and remind you that it's high frequency. So it wasn't just luptup, luptup. It was luptup, luptup, luptup. Try that. Luptup.
I can't do that.
And what does that mean? That is a mid-systolic click. Sometimes you hear multiple mid-systolic clicks. And when you hear that, you want to listen hard to see if you also hear a murmur. In this case, we did not. And what's the pathophysiology? This is a young woman with mitral valve prolapse. The valve is a bit more redundant than normal. The chordae a bit elongated. And as the ventricle contracts, those structures snap back and generate that mid-systolic click. Concentrate, listen in mid-systole, tune in.
The systolic click
Tune
is
in.
a
Lock in.
clicking quality.
Lock in,
Although it is
team,
often
lock
best
in.
heard over the cardiac apex, it can be transmitted widely. There may be a single click occurring as an isolated finding in mid to late systole, or there may be multiple clicks. The mechanism of the click is abrupt tensing of the prolapse portion of the mitral valve during mid to late systole. This is similar to the popping sound created by a sail or parachute just as it reaches the point of full expansion. This is a graphic example of a mid-systolic click followed by an S2. Let us listen together.
This shit is so crazy, by the way. Oh my god. That is actually crazy that medium boiled eggs is not a thing in on the wiki. You know? Maybe.
We now want to focus on the auscultatory events in a patient with an innocent murmur.
Maybe, I mean, like, maybe it's just what people just colloquially call not soft, not hard-boiled eggs.
A young man in high school went out to the athletic team, and a nurse did a screening exam, and she was sure this was an innocent murmur. And why? Well, let's all listen together and see if we can decide if it's an innocent murmur. We'll listen at the upper left sternal edge. We'll use firm pressure on the diaphragm. The carotid is there for timing. Everyone listen together and watch breathing as well. We just heard a classic innocent murmur. That murmur is generated across the pulmonary outflow tract in a young person with a vigorous circulation. The murmur is early in systole because it's due to turbulence alone. Remember, it's in the first third of systole that 2/3 of blood leaves the ventricle. Now, let's dissect out what we heard to confirm that. The first thing we heard was the murmur. And the second
It gets middle medium thing. Yeah, just don't be mid.
It was short, so you heard not lup-tup, 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 but lup-shtup, 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 short.
Lup-shtup,
After the murmur,
lup-shtup.
the second heart sound.
I like that. That's funny.
Try it.
Mimic that. Lup-shtup.
Lup-shtup, lup-shtup, a short murmur due to flow alone. And
Ah!
the thing we heard was normal.
I don't want to have hair right now.
In a patient who had a flow murmur, for example, from an atrial septal defect, that second heart sound would likely have been fixed split. In our case, this is an innocent murmur generated across the outflow tract in a young
Lup-shtup is innocent.
The murmur is best heard at the upper left sternal edge or pulmonary area. Note the position of the pulmonary valve in relation to chest wall landmarks. Turbulent systolic flow across the pulmonary outflow tract
Oh
generates
my
the murmur
god.
and is well heard in the second left intercostal space. The murmur heard at the upper left sternal edge is systolic,
Lap
short,
shit up.
early peaking, crescendo decrescendo, and mid-frequency. Murmurs at the upper left sternal edge that occur early in systole typically result from turbulent flow when the majority of blood is ejected from the right ventricle. This is a graphic example of an innocent murmur. By simultaneously viewing the ventricular volume curve, we can see that 2/3 of the blood ejected leaves the ventricle in the first 1/3 of systole. Therefore,
But then if I
the
put
innocent
my
flow
hair up,
murmur,
it
due to turbulent
hurts.
flow across
What do I
the pulmonary
do?
outflow
I don't want it. I
occurs
don't want
in
it.
early systole.
I don't want it. I don't want it. I wasn't listening. It's crashing about my hair.
The
Someone-
second
can someone
flow is
hold it?
ejected from the right ventricle. This is a graph of your pulmonary area. Note the position of the pulmonary valve in relation to chest wall landmarks. Turbulent systolic flow across the pulmonary outflow tract generates the murmur and is well heard in the second left intercostal space. The murmur heard at the upper left sternal edge is systolic, short, early peaking, crescendo decrescendo, and mid-frequency. Murmurs at the upper left sternal edge that occur early in systole typically result from turbulent flow when the majority of blood is ejected from the right ventricle. This is a graphic example of an innocent murmur. By simultaneously viewing the ventricular volume curve, we can see that 2/3 of the blood ejected leaves the ventricle in the first 1/3 of systole. Therefore, the innocent flow murmur, due to turbulent flow across the pulmonary outflow tract, occurs in early systole. The second heart sounds at the upper left sternal edge demonstrated normal splitting and intensity. No abnormal sounds were heard. The
Skinwalkers and
combination of an early
doppelganger.
systolic flow murmur with normal splitting of the second heart sounds is consistent with a diagnosis of an innocent murmur.
We're now going to examine a patient with classic mitral regurgitation. This patient moved here from South America not long ago, and she's had a murmur known for years after she had had rheumatic fever. We examined her and find no other abnormality, but we listen at the apex, and let's listen together, and we hear the classic murmur. Everyone listen.
Everyone listen. Listening?
Pressure on the
Are you listening?
That is the typical murmur of mitral
Okay, do it again.
regurgitation.
Leapt up. So it's longer
That
and
is
more
the
annoying.
typical murmur of mitral regurgitation. Apex, high frequency, radiates back toward the axilla. You mimic it by going shh, shh. It's like telling someone be quiet.
Shh.
You do that. It's
My
throughout
neighbor and
all
his
of system,
babe.
because the pressure is higher in the left ventricle than the left atrium during all of that time. It's high frequency because of the big pressure difference between the left ventricle and the left atrium. Do it again. Mimic it.
Do it again.
Mitral regurgitation. Common, important murmur.
The murmur is best heard at the apex.
I hate how
mitral
it's so
area, and its
loud.
location is related to the underlying lesion. The left ventricle is anterior to the left atrium, and regurgitation through the mitral valve usually results in turbulent posterior flow with radiation of the murmur toward the axilla. This is a graphic example of the heart in a patient with mitral regurgitation. In the animation that follows, we can appreciate that the murmur is generated across the regurgitant mitral valve during left ventricular systole.
Oh my god. My room has suddenly gotten really fucking hot for no reason.
These simultaneous left atrial, left ventricular, and aortic pressure curves illustrate the relationship of the hemodynamic events to the timing, contour, and frequency of the systolic murmur. The murmur begins with mitral closure obscuring the first heart sound. It continues up to and through aortic closure as left ventricular pressure exceeds left atrial pressure throughout this period. The murmur is plateau-shaped because there is a significant pressure gradient between the left ventricle and left atrium throughout all of systole. The murmur is high in frequency, primarily because blood is flowing from the high-pressure left ventricle to the low-pressure left atrium.
There are many causes of mitral regurgitation, and amongst the most common is mitral valve prolapse. The character of that murmur on auscultation is distinctly different than the classic holosystolic murmur of mitral regurgitation. Let's all listen at the apex, time the murmur and systole with the carotid, firm pressure on the diaphragm. This is not the holosystolic rather it's flop, flop, systole crescendo introduced by a click, the k. So it's flop, flop, flop. You mimic it. Flop, flop, flop.
I'm actually good on that one.
Common murmur you'll hear on patients you examine, mitral valve prolapse.
In a patient with a mid to late systolic murmur, early systole is silent. Our patient has several mid-systolic clicks that introduce the murmur. The murmur crescendos into the second sound and is high frequency.
We're now going to examine a young man with severe aortic stenosis. He became lightheaded as he went to run and catch a baseball. And his family was quite concerned. He came to you. There's actually been a history of a murmur in the past. When you examined him, you found his carotid vessel was a bit small, slow rising. It was a larger than normal impulse, more sustained on the chest wall. And then you listen at the upper right sternal edge. Again, we'll time this with the carotid vessel. And let's all listen together.
I think it's rude of him to expect me to be able to make those sounds.
Aortic stenosis. Let's mimic it together. Upper right sternal edge. It's mid-frequency, almost groaning. You do it. Let's see how you can groan.
He makes me wants me to groan.
Now, why do I say severe? Well, to begin with, the murmur was
I think
long.
he's weird for that, no?
That means even during periods of relatively modest flow in late systole, there's enough stenosis to cause turbulence and generate that audible murmur. In addition, of course, we did more than just auscultation. The carotid pulse was a bit small, and there was a sustained apical impulse. All of this tells you that this is significant aortic stenosis. Let's mimic it again. Radiating up from the upper right sternal edge, even into the carotid vessel.
The murmur is best heard at the upper right sternal edge or aortic area, and this location is related to the underlying lesion. Note the position of the aortic valve in relation to chest wall landmarks. Stenosis of this valve results in turbulent systolic flow in the direction of the upper right sternal edge. In many cases, systolic vibrations may be palpated as a thrill in this area. This is a graphic example of the heart in a patient with aortic stenosis. In the animation that follows, we can appreciate that the murmur is generated across the stenosed aortic valve during left ventricular systole. These simultaneous aortic and left ventricular pressure curves illustrate the relationship of the hemodynamic events to the timing and contour of the murmur. The murmur begins with the opening of the aortic valve as left ventricular pressure exceeds aortic root pressure early in systole. The crescendo-decrescendo configuration of the murmur is related to the changing pressure gradient between the left ventricle and the aortic root in systole. The long length of the murmur reflects significant obstruction, as there is a gradient and hence turbulent flow throughout most of systole. With pulmonary stenosis, analogous events occur on the right side. The murmur of aortic stenosis must be differentiated from the murmur of aortic sclerosis. The murmur of aortic sclerosis is commonly heard in older patients and is due to early systolic turbulent flow across a fibrosed aortic valve in the absence of significant obstruction. Like the murmur of aortic stenosis, this murmur is best heard at the upper right sternal edge, is systolic, crescendo-decrescendo, and mid-frequency. In contrast to the long, late-peaking murmur of significant aortic stenosis, it is short and early peaking, as it occurs when the majority of blood is ejected from the ventricle in early systole.
I wasn't listening, but I don't think I really care. Ew.
Now we're going to learn a very important diastolic murmur. The heart sits in the chest like your fist, and the aorta goes in this direction, so aortic stenosis, narrowing the valve, the murmur goes up in this direction. But with aortic regurgitation, it goes down in this direction. So you hear the murmur of aortic regurgitation best at the mid-left sternal edge, the direction of flow. Let's everybody listen together. Timing of the carotid.
Hold on. I'm gonna check how much I need for this test. Because... little blow. Yeah, I just... kinda tired.
I use very firm pressure of the diaphragm on the chest wall in order to bring out this high-frequency diastolic decrescendo murmur. It's high frequency because the leak is from the high-pressure aorta into the lower pressure ventricular chamber in diastole, and you hear lup, lup, lup. You do that. Lup,
Lup, cool.
lup. Classic diastolic decrescendo murmur of aortic regurgitation. And by the way, significant aortic regurgitation is also reflected in the fact that the carotid vessel is bifid and rapid rising, and the apical impulse is displaced and hyperdynamic. Aortic regurgitation. Lup, lup, lup.
The murmur is best heard at the lower left sternal edge, and this location is related to the underlying lesion. Note the position of the aortic valve in relationship to chest wall landmarks. Regurgitation from this valve results in turbulent diastolic flow in the direction of the mid to lower left sternal edge. This is a graphic example of the heart in a patient with aortic regurgitation. In the animation that follows, we can appreciate that the murmur is generated across the regurgitant aortic valve during left ventricular diastole.
There's what? What does that mean?
These simultaneous aortic and left ventricular pressure curves illustrate the relationship of the hemodynamic events to the timing, contour, and frequency of the murmur. The murmur begins with the aortic sound because the aortic root diastolic pressure exceeds left ventricular pressure immediately after the onset of diastole. The murmur then diminishes as aortic root pressure falls and left ventricular pressure rises in diastole. Because the pressure difference does not disappear, the murmur is long. The murmur is high frequency primarily because blood is flowing from the high pressure aortic root to the low pressure left ventricle. When pulmonary regurgitation is due to pulmonary hypertension, analogous events occur on the right side.
The next important bedside finding we should know is the murmur of mitral stenosis. Now, the mitral valve, of course, is open in diastole, but if it is narrowed, stenosed, then a rumbling, low-frequency murmur is generated. Let's all listen together at the apex with the bell for low-frequency sound, using the cotton swab to measure systole and therefore diastole. Everyone listen together. we heard the classic murmur of mitral stenosis. Light pressure on the bell at the apex to appreciate the low frequency sound, and you hear rup, rup, you mimic
Oh my god, he's growling at.
There are many features that tell us this is severe, most important of which is the length of the murmur. Remember that when you're dealing with a valve that is stenosed, the longer the murmur, the more severe the stenosis, because even during periods of relatively modest flow, there's enough narrowing of the valve to generate turbulence that you appreciate as the murmur. Now, in addition to that, when you do the rest of the exam, you feel an impulse at the parasternal edge. It's a right ventricular impulse. And when you listen at the upper left sternal edge, you hear lup-doop, a loud pulmonary second sound. This tells us this patient has pulmonary hypertension with a loud P2 and with a right ventricular impulse. All of this, length of the murmur.
Hello, Vicky.
This is severe mitral stenosis.
I'm full from the get-go. Oh, good lord.
A definite history of rheumatic fever, and she has rheumatic mitral stenosis, and it is severe. Let's mimic that murmur one more time.
Apex or mitral area, and the location is related to the underlying lesion. The left atrium is posterior to the left ventricle, and flow through the stenosed mitral valve results in turbulent anterior flow toward a localized area at the apex.
My back hurts. Get it fixed.
Mitral stenosis. In the animation that follows, we can appreciate that the murmur is generated across the stenosed mitral valve during left ventricular diastole. These simultaneous left atrial and left ventricular pressure curves illustrate the relationship of the hemodynamic events to the timing, contour, and frequency of the murmur. The murmur begins with the opening of the mitral valve as atrial diastolic flow enters the left ventricle. It is long as a gradient between the left atrium and left ventricle persists throughout all of diastole. There is an early diastolic accentuation of the murmur as most diastolic flow occurs at this time, and a presystolic accentuation as left atrial contraction again augments flow. The murmur is low frequency, primarily because blood is flowing from the relatively low pressure left atrium to the low pressure left ventricle.
I feel like these are important to know, but right now I'm just kind of way too tired to.
You should also be aware of and be able to identify a murmur that is called a continuous murmur. That term actually applies to the fact that the murmur continues through the second heart sound. So there's a systolic and a diastolic component. Classically, it's found in a patient with a patent ductus arteriosus. Let's listen together in a patient that simulates that and use the carotid impulse to time systole and listen at the upper left chest together.
Holy shit, bro.
That murmur is impressive, and it's easy to mimic.
Okay, bye, croissant.
The pathophysiology of that murmur
Through the window. Okay.
between in this case, the aorta and the pulmonary artery through the ductus, both in systole and diastole, and that is what generates the continuous type of murmur you heard. Let's mimic it one more time. A continuous murmur.
A continuous murmur begins in systole and continues through the second sound into diastole. Such murmurs result from turbulent flow originating in blood vessels. Continuous murmurs may be due to rapid blood flow, such as the venous hum heard in children in the clavicular area. They may also be due to shunts from high to low pressure vessels, as seen in patients with patent ductus arteriosus. Finally, they may be due to localized arterial
Okay.
without adequate collateral circulation. Note that the murmur continues through the second sound and is high frequency. Let us listen together.
You should also know the murmur of tricuspid regurgitation. It's very much like mitral regurgitation, but it's heard over the so-called tricuspid area at the lower left sternal edge, and it may behave in a unique manner during respiration. That is, during inspiration, it may become augmented. Let's everyone listen together while we watch breathing, and we look at the carotid vessel for timing. What you heard was you do that, mimic it.
I'm okay.
What happens is that when the patient breathes in, Intrathoracic pressure drop.
Choo choo
That brings more
choo.
blood back to the right heart during inspiration, hence augmenting the murmur of tricuspid regurgitation. Tricuspid regurgitation most often occurs in the context of other heart disease, as in a patient with pulmonary hypertension and right heart disease. Again,
No.
tricuspid regurgitation is augmented during inspiration.
This is a graphic example of the holosystolic plateau-shaped murmur of tricuspid regurgitation. Note that the murmur increases with inspiration and that it is high frequency. Let us listen together.
We should all be able to recognize a pericardial friction rub. Our patient, about a week ago, had a respiratory infection. Now he has somewhat sharp chest pain relieved by sitting up. Let's listen to our patient. At the lower left sternal edge, where in this patient the rub is the loudest, we'll time the events with the systolic impulse of the carotid vessel by looking at the cotton swab. Everyone listen together.
What?
And also watch respiration.
Endorsement 5. Endorsement 5 tank? I'm sorry, I'm not listening to this. What? This bitch is going ba-doop, 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 ba-doop.
Our patient has a classic three-component friction rub.
My brain hurts.
You mimic that.
Ba-doop, 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 ba-doop.
In our case,
Look, have
it gets louder with
fun.
expiration, but it get louder with inspiration or not change at all. Now, what is the cause of those components? Well, it's when the heart moves within the pericardial sac, during systole, during contraction, during rapid filling and early diastole, and during late diastolic filling. You must have at least two components to diagnose a friction rub. One more time, mimic.
Ba-doop, 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 ba-doop.
Pericardial friction rub.
Pericardial friction rubs are due to inflammation of the pericardial sac. They are best heard with the patient leaning forward at the end of forced expiration, using the diaphragm of the stethoscope. Rubs are often most prominent between the lower left sternal edge and apex. They are high-pitched and scratchy in quality, and are often subtle and vary in intensity. The classic pericardial friction rub has three
Ba-doop,
components:
ba-doop.
systolic component during ventricular contraction, a presystolic or late diastolic component at the time of atrial systole, and an early diastolic component during rapid ventricular filling. Two components should be present to diagnose a rub, as a single component systolic rub cannot be reliably differentiated from a scratchy systolic murmur.
Oh, for real? Oh, for real? Oh, that's sick, actually. Oh. I did it. Stenosis. Hello, Lispy. Sick. Sick. Uh, 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 um. Holy shit. Ba-doop. Up-a-tap, up-tap, up-a-tap. Could be a click. Maybe 4 sound. I'm gonna say click. That's fine. Go. Where are we? We are AV mitral. Fuck. Wait, is this stenosis or regurgitation? Probably stenosis. Okay. Aortic stenosis. RP ASMR goes crazy. Booped. 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 Think? Fuck. Fuck. Okay, I think so. It's stenosis, right? Okay, so we can actually. Holy shit. It doesn't sound like regurgitation, so therefore it's not a regurgitation. If it sounds like a regurgitation, it's a regurgitation. Sound the same. Don't they gotta look the same? Oh well. This is regurgitation. What kind of regurgitation? Is it mitral? Tricuspid? Fuck. It's innocent. Oh my good lord. Hi Moo Moo. Hi Moo Moo. Hi Gloomy. I'm just reading. Moo Moo. Oh, empty. Boop up. Oh my god. Aortic. Oh, let's fucking go. Oh my god. I don't know. I don't know. Fuck. Okay, so if it's coming on S1, S1, lub, dub, lub. That means your ventricle is the problem. Which means it's aortic. That sounds like regurgitation. No, we're gonna say aortic stenosis. Fuck. It's both of them are wrong. Oh well, I think I got these wrong too, to be honest. Sick. Get program credits? Oh. Credits for the program. Wait, what did I just close? Oh. Alright. My brain hurts, I won't lie. I might stop. I don't know. My head does actually hurt. How much more do I gotta do? Like a lot, actually. I'm kind of tired as hell. Maybe I take a nap and then come back to it, but not to streaming, I don't think. Okay, end streaming here. Shit. Okay. eye ending. I need to take a nap. Bye bye. Whoop, 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 whoop. Thank you for watching. How do we watch Raid? Um. 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 I don't know. I don't think we made a new one. Hey, GG's. Have fun. Goodbye.